वनी सर, आज आपकी बातों से रोशनी होगी सर।
Emergency lights are there.
Okay. Good afternoon, everyone. Good afternoon, all the attendees. Welcome all the panelists, Dr. Pratap Sharma, Mr. Ajmer Singh, and our Director General, Mr. Arun Kumar Jha, IES. Today's topic is very crucial. It's mental health and suicide prevention. And without wasting any more time, I would now like to request Mr. Ajmer Singh, who's been collaborating with us in this initiative for healthcare awareness to make people feel better and covering all the health aspects, whether it's mental health or physical health. So, sir, I would request you to please introduce our speaker and the topic today.
Thank you, Jalendu. So, as Jalendu said, we are discussing a very crucial topic today, that is mental health and suicide prevention. And I must extend welcome to Dr. Pratap Sharma, and one of the India's finest psychiatrists. He's professor at Department of Psychiatry, AIMS. He's MBBS, MD, PhD, and his field of interest is adult psychiatry, public mental health, personality disorder, child and adolescent psychiatry. And I just went through your profile, sir. I mean, you have 8 books and 69 papers to your credit, sir, and plus experience at international research. If I may quickly read from it, that in the area of international public health, the World Health Organization involved in research on mental health resources in all countries of the world, and on mental health research infrastructure of selected low and middle income group countries. Also carried out systematic search and epidemiology of mental disorders, and then which has led to strengthening services delivery and research system in a few countries. The project on mental health publications led to development and editors group, which in conjunction with WHO is now making active efforts to support researchers and journals in low and middle income countries to find increased international acceptance. As I said, it's a very crucial subject. I mean, we are all passing through very difficult times, and especially during this pandemic, the stress levels have really gone up. And we have had too many suicides in the recent past, especially 16-year-old and 18-year-old kids dying by suicide. And in fact, my gratitude to Mr. Arun Jha sir also. I discussed it with him that somebody asked me that why are we getting into this. So I was deeply troubled by this, rather traumatized by this. Too many newspaper full of especially frontline workers, doctors from AIMS dying by suicide. So personally, it was deeply troubling, and I discussed with Arun Jha sir also. He was kind enough that we should organize. We call it counseling sessions, and so he kindly agreed to provide National Productivity Council webinar, and I think it's extremely rare. It's the only mainstream government organization to organize free webinars on mental health. Idea is, as Mr. Jha sir suggests, that we should reach out. We keep discussing, how do we destigmatize depression? How do we reach out? I mean, especially during these highly stressful time. So welcome to you, sir. And there are too many questions, so everybody is sort of waiting to hear you. I hand over to Jalendu, sir.
Thank you so much, sir, for introducing the topic so clearly. Now, I would like to request our Director General of NPC, Mr. Arun Kumar Jha, IES, to address everybody and give an introductory note. Over to you, sir.
Thank you, Jalendu. Thank you, Ajmer. First of all, I would like to welcome Dr. Pratap sir, Secretary AIMS, on our webinar. And I'm thankful to him for having given us time for this very important topic and taking valuable time out of his own busy schedule. I'm fully aware of how much busy doctors and AIMS are, and that will be in this time. Dr. Sahab, let me tell you that we are doing a great service for the mankind. And each one of us here needs your advice. Whether we say that we are okay, but still we need your counseling. And I think, and I I'm sure that after your advice, we all will be more calm and peaceful. And so our participants. So I welcome all our participants. We are still adding up. Large number of participants are here for hearing this kind of discussion and advice because whosoever is the victim of this, he leaves behind large number of people who bound for him and always make themselves responsible for his death and his commission of acts. Because I also have seen such things from very near, and I know how deeply people are discussing about all this. My only takeaway is that if there are reasons for committing suicide, there are much more reasons to survive, much more reason to live. So how do we live purposely? How do we, fight all these mental stress? What are the traits which will take us to that level? We all should know about it, and I think in today's discussion, we will be able to cover this, and we will come out stronger and more calm and peaceful. Thank you very much, sir. Over to you, Jalil. I will request Dr. Pratap Sharma to start. I think Jalil has not some so let me take the responsibility of requesting you. Thank you, sir. Please start.
Uh, Thank you, Shri Arun Kumar Jhaji. I would also like to thank the National Productivity Council for making these webinars and taking the message of mental health to the people. I'm also thankful to Mr. Ajmer Singh for coordinating and organizing this talk. I'm very happy to be talking here, even though the topic that I'll be talking on is rather somber. And let's see how we make progress. I'm not a great orator, so I'll be making a presentation with slides. Okay, the basic topic that I'm talking on is actually suicide prevention and how mental health is associated with that. The issues to kind of understand is that suicides are common and the global average is about 10.6 per lakh. So it's about one person out of 10,000 who dies, which is not a very small number because about 8 lakh people uh, die per year because of suicide in the world. At the world level, it is believed that older people are more likely to die by suicide, while and men to women ratio is 2:1. But if we look at the India data, the rate of suicide is about 1.5 times that of the general global average. And it is believed that this is an underestimate by 2 to 5 times. So actually, the suicide rates in India are pretty high. The other differences in India is that about 70% of people who die because of suicide in India are below 45 years of age, and relatively more women commit suicide in India than in the rest of the world. So the men to women ratio is about 1.5:1 rather than 2:1. So there are differences in the way Indians kind of deal with issues related to suicide. It's also well understood that the suicide rates are different in different regions of the world. Like, for example, the rate between Europe and the Middle East is about 4 times. And this is the most important reasons probably are socio-cultural, like religious affiliation or group cohesion. But it also has something to do with access to lethal means of dying by suicide and whether treatment for mental disorders are present or not, adequately available or not. Some of the common means of committing suicide are hanging and use of pesticides. Uh, at the world level, the use of pesticides accounts for about 20% of deaths due to suicide, while in India, the pesticides probably account for about 40%. So India has a different profile in general. if you look at like if the Sustainable Developmental Goals has made suicide reduction kind of one of the uh, uh, points, the key points on which action has to be taken. And there has been sustained attention on suicide reduction from, I think, late 1990s. And this has led to a 18% decrease in the rate of suicide between 2000 and 2016. Uh, and the reasons for this reduction has been concerted efforts to detoxify domestic gas, for example, in UK, where carbon monoxide was removed from domestic gas. Similarly, the sale of alcohol was restricted significantly in Russia, and Russia took up a lot of efforts at educating people to decrease the use of alcohol, and this led to a decrease in suicide rate in Russia and in most of Eastern Europe, which had very high rates in the late 1990s. So over the next 20 years, the rates came down to more than the world level, but more than the world average level, but below, it kind of halved almost from where it had reached in the late 90s. Similarly, United States, some of the states in the US have started restricting the sale of firearms, and this has led to a decrease in suicide rates in those states. In India, on the other hand, the rates of suicide increased by 43% between 75 and 2005. So while the world rates are coming down, the rates in India are going up, even though bulk of this increase happened in the last century. From 2000 onwards, the rate of increase has been much more gradual. It's probably about 5% now. So the bulk of increase happened earlier. Now, there is a difference in the concept of self-harm and suicide. This is something that needs to be understood, that about for every for about 200 people who think of dying by suicide, about 20 attempt it. That is, 1 out of 10 will attempt a suicide, and 1 out of this 200, or almost 5% of the people who make an attempt at suicide actually die because of suicide. So there is a kind of a telescoping. The other issue is that the people who attempt suicide and people who die by suicide are slightly different groups, in the sense that people who attempt suicide are likely to be younger. The majority of them are younger, and the majority of them are women. So this may have something to do with the kind of illnesses that people suffer from, as well as the means that are available. Like, if more dangerous means are available to older men, they are more likely to die because of suicide, even if more people attempt uh, uh, suicide for reason. Like, young women may often try to overdose with medication, and that is less effective, as well as when people try to cut their wrist or something, that is less likely to be lethal. While if a person tries to shoot themselves by with a gun, or they try jump from a high-rise building, that is more likely to lead to death. So that's the reason why there are differences in people who attempt and people who die by suicide. Of almost the 5% of people who die because of suicide after attempting it, almost 1/3 of them will die within the first year of that attempt, and almost 4% will die within the next 5 years. So the issue with suicide deaths is that if a person has made an attempt, the deaths may not occur with that attempt, but a person who has made an attempt is likely to be thinking about the same thing and may make attempts later. That's why it's important that if a person has made an attempt, we kind of identify them and treat them, or take care of them in some way. Now, uh, the risk factors that affect suicide uh, are different across the lifespan. So if we look at the slide, the factors which are kind of shown in orange are individual level risk factors. These are factors which are directly related to individuals, and those which are shown in green are related to environmental risk factors. So what we find is that there are certain things like genetic and epigenetic factors and family history which affects suicide starting from the time of conception till the time that a person is old. While some of the others, like early life adversity, will start affecting people in mid-childhood. Psychiatric disorders, including severe mental illness and depression and personality disorders, they start becoming important at about the middle of adolescence. Substance use becomes more important when a person is in early adulthood or middle adulthood, and physical health problems become more important in middle to later adulthood. Uh, on the other, in the environmental factors, lack of social support is almost always important, and similarly, severe life events, which means stressful events, these are always important. And also, access to lethal means will be important if if death due to suicide occurs. Effect of the media starts becoming important in middle of adolescence, but is most prominent in adults. And economic factors are important when a person is at the age when they're supposed to start uh, sustaining themselves or supporting their families. So the factors that may affect suicide vary across the age span. Uh, Among the predisposing factors to suicide, the most important one is probably mental illness. And in Western countries, it has been found that at least half of suicide deaths are related to mental illness. In India, however, the rate of mental illness in completed suicide is about one-third. So India again is slightly different from the rest of the world in terms of the risk factors for suicide. Amongst mental illnesses, the common conditions which lead to suicide are depression, bipolar disorder, which is a disorder in which a person may get depressed or at other times when they become very excited. Uh, then there is schizophrenia spectrum disorders in which people have delusions and hallucinations. And another set of illnesses which have a lot of potential for suicide deaths is substance use disorders, which is alcohol or other drugs. And each of these conditions, when they are like substance use means not that anyone takes a little bit of alcohol, a little bit of substance or of drugs. It's when it becomes addiction. It becomes a dangerous thing when it is at the level of an addiction, or if a person is very intoxicated. Like a lot of like if a person is very intoxicated, sometimes their judgment may be impaired and they may take decisions which they would not take otherwise, which can include decision to die also. So each of these conditions is associated with increase in rate of suicide by about 3 times. Suicide also occurs in the absence of identifiable psychiatric disorders, however, like at least about half or maybe even two-thirds of suicides may not have a clear-cut psychiatric disorder. And sometimes it's possible that a person may have a mental disorder and they may also have other risk factors. So other risk factors may co-occur with a mental disorder. And some of the important other factors are previous suicide attempt, childhood sexual abuse, family history of suicidal behavior, and loss of a parent by suicide in early childhood. Now, the factors that we have talked about are kind of vulnerability factors. These have been present in the person from earlier, and sometimes this kind of a predisposing factor interacts with something which is called a precipitating factor, something which occurs in the here and now. And this may lead to the precipitation of suicide rather than just the presence of the predisposing factor. And some of the precipitating factors are stressful life events, like if a person has relationship difficulty, particularly following a separation or a divorce, or it could also be a breakup in a relationship, a death of a partner. Death by suicide of someone close is particularly important, and especially when mothers whose adult children die by suicide, they are more likely to think about or complete the act of suicide. Receiving a diagnosis of chronic mental conditions can also, chronic medical condition can also lead to people feeling very disheartened. It has been shown that in the first week of diagnosis of cancer, there's a slightly higher rate of suicides than at other times. People who have been assaulted would could think of dying by suicide soon after the assault occurs. And similarly, people who have been arrested or imprisoned may think about dying by suicide soon after uh, these events occur in their life. At a population level, natural disasters are times when more people may think of dying suicide. Paradoxically, it has been found that terrorist attacks is protective because victims of terrorist attack tend to be more socially cohesive. So, like with the New York, the trade tower disaster, the rate of suicide in New York had actually come down for a few years. Similarly, suicide of a celebrity may increase the risk of suicide, and the Sushant Singh Rajput issue might have played a role in some of the suicide that occurred after that. This becomes more important when the press guidelines are disregarded. Normally, the press is supposed to be very kind of conservative in reporting suicide, that they shouldn't be putting it on the first page, they should put it inside. They shouldn't talk about the means of by which the death occurred. They should give information about how help is available, and that suicide is usually due to mental illness, and that it's not a good kind of solution to problems. There are other ways of solving problems. So if there is responsible media reporting, the rates of suicide are less. If there is irresponsible media reporting, the rates of suicide goes up somewhat. And particularly, there is something called copycat suicides, where adolescents or young people, they sometimes die by the same means as what the celebrity had tried. Other problems at a population level may be economic adversity. Here, I'm not talking about a loss of a job kind of a thing. It's more about the kind of thing that we see in COVID, where there is a economic depression on the whole, and lots of people have kind of lost jobs. So it's not only that the person who loses job is under stress. The entire family, and sometimes their joint family, and sometimes the community may be under stress because it's such a widespread thing. So that is what is meant by population level economic adversity. Then there are certain professions which have high access to lethal means of suicide, like farmers and nurses, veterinarians, physicians, and police. And uh, uh, Mr. Ajmer Singh mentioned that there seems to be a higher rate of death during COVID amongst physicians. And one of the reasons is that they have kind of a more access to lethal means of suicide, apart from the stress that COVID situation is causing for them. A religious affiliation is believed to be protective, but it doesn't work if the religious group is a minority and is socially isolated. Some of Many people think as to why people ultimately die. Like as Mr. Shah mentioned, that there should be many more reasons to live than to die. So what pushes some people to die? One of the important models is called a stress vulnerability model, which basically means that if a person is vulnerable from before, uh, when they are faced with stress, they think of dying by suicide as a way of handling their problem, rather than thinking of other ways of handling the problem. And some of the vulnerability factors which are important are impulsivity, particularly among the young. People who are impulsive may act on the suicidal ideation, while people who are not impulsive may think about it and then they kind of think of other ways of solving the problem. People who are perfectionistic, they sometimes become very stigmatized by the fact that they have a crisis. So they want to live life without any kind of social stigma. And so when they have a crisis, they feel that they are responsible for it somehow, and there is no other way of managing the things. They don't want to get any kind of a ill fame at all. So even if they have a crisis in their life, they would want to be away from the spotlight. People who have very fixed ways of working, and people who tend to ruminate a lot about their problems, sometimes find it difficult to look for other methods of solving problems, and this can also be one of the reasons why they may choose suicide as an option rather than more functional options. Now, if this stress vulnerability is kind of added to interpersonal psychological sense of burdening others. So if a person who is vulnerable faces with stress, if he starts feeling that they will become burdensome to other people or that the social groups will not accept them, and particularly if they feel that this view of the society is not going to change, they become more inclined to think of suicide as a way out. And if this is added further to people who have already attempted self-harm at some points of time in their early life, they often have less fear of death because they have come close to it, and they kind of become familiar with death. And if they have tried to harm themselves, they also know what kind of pain is going to be there, so they are kind of less scared of attempting it again in certain ways. So if all these factors play together, the chance of trying to die by suicide increases. We know that there are many familial, genetic, and biological factors which may be important, like family history of suicide may be important, which is partly because uh, family history also explains mental disorder and impulsivity. So people who have a mental disorder and impulsive because of the genetic risk may have higher genetic risk of committing suicide also. Then there are uh, it's been found that mother's suicidal behavior is more important than the father's suicidal behavior, and the effect is greater on younger children. So if a family member died by suicide when the child had become an adolescent, they may not follow that example. But a younger child is, the mind is more impressionable, and if a very young child knows that my parent died because of suicide, they have less kind of abhorrence for that as a method. They feel that it's a more acceptable way of handling problems or handling death. Other biological factors are serotonergic pathways, then the hypothalamic pituitary adrenal axis. And one of the regions which are important is medial prefrontal cortex, which is important in decision making, amongst other functions. Okay. Some of the, with all these kind of predisposing factors and etiological factors, there are certain groups which are more at a higher risk of dying by suicide, and one of them, as we have already mentioned, is mental disorders. Uh, Other groups are people with high social adversity, like people who are homeless, children who live in foster care, people living in sheltered housing or nursing homes, so largely people who are kind of abandoned, and those who are incarcerated. So suicide rates are usually higher than other places in prisons. And for these populations, careful monitoring is required, and community should be aware that these people are under more stress than others. Coming to suicide prevention methods, the first set and the most evidence-based set of uh, interventions are population-based, and one of the major ways of decreasing the rate of suicide at a population level is to decrease the access to means of suicide. So one should be trying to restrict uh, methods which are known to be lethal and which are known to be frequently used in that community. Like for example, in India, it would be pesticides would be a very important way of decreasing suicides in India. So ban on sales of hazardous pesticides has led to decrease in suicides in Sri Lanka, Bangladesh, South Korea, and also there are reports which would suggest that the rates have, like after there was a ban on endosulfan in India and in Kerala particularly, the rates may have come down in Kerala to some extent. Similarly, it has been found that putting up barriers at potential suicide spots like bridges or tall buildings or railway tracks may decrease the rate of suicide from those spots, and even maybe at the overall rate of suicides may also come down. Other suggestions have been to have smaller pack sizes for non-prescription medication used for suicide, like paracetamol. Sometimes, if it's taken in kind of big numbers, can lead to suicide through its effect on kidneys, and similarly dextropropoxyphene, which is an opioid given for pain. These medication, if they're sold, they should be sold in small numbers so that people cannot kind of stock them up in their own homes. Gun restrictions, as I mentioned earlier, have been found to be useful at a population level. And there is some effort at removal of ligature points. Ligature points are basically points from where a person can hang themselves. So if these are kind of brought down, the rates of suicide do come down. An example is that now it's possible to have fans which can, if there is a pressure beyond a certain weight, they split up in such a way that the rod will break and the fan will not fall on the person. So there's a cage below the fan which will stop the fan from falling on the person. At the same time, the rod will break, and so a person cannot hang themselves from the fan rod. Other interventions which have been found to be useful are early interventions for psychosis, which in Hong Kong, and the school-based suicide prevention program seems to have worked in Europe, even though this seems to work only if it is well organized. So having a random kind of suicide prevention program at school doesn't work. If it is done in a proper manner, it seems to work. Some of the pharmacological treatments which work in individuals are mentioned here. So that you have a sense that there are some medicines which may decrease the rate of suicides if they are given for conditions for which they are meant. So lithium will work in bipolar disorder or depression. It will not work for a social cause of suicide. Similarly, clozapine will work for people who have schizophrenia. In reducing the rate of suicide, it will not work for other conditions. So these are meant for disorders and not for suicides per se. But what has been found is that some of these medicines decrease the rate of suicide in these specific populations. Among psychological treatments, it has been found that if the treatments which focus directly on suicidal thoughts and behavior and provide strategies for coping with suicidal thoughts and behavior, then the rates of suicidal behavior comes down. While other kind of therapies which focus on mental disorders and do not focus on the suicidal behavior, they do not seem to be particularly useful for decreasing suicidal behavior. They may take care of the basic condition, but to take care of suicidal behavior, one has to address it directly. And some of the therapies which have been found useful are cognitive behavior therapy, mindfulness-based cognitive therapy, which is basically CBT with meditation, and a specific kind of therapy called dialectical behavior therapy, which focuses on trying to keep people in treatment, in making people more emotionally stable, and in making them more mindful of what goes on in their mind, so which is using some kind of meditative techniques. In COVID times, for example, it's important to mention that internet administered self-help treatment is being tried, even though right now it's a bit early to say whether this will work or not. Community-based interventions are important because suicide is not just a health issue, it's a social issue, and it is everybody's duty to save lives in that sense. And some of the things which can be done is community education, like destigmatization of mental illness and suicide, improving social connectedness, teaching people how to cope and with adversity and how to manage their problems better by having more flexible ways of problem solving. Community engagement can also be used to reduce excessive alcohol use and regulate drug and other addictive substances. Life skills education in children and adolescents may be promising, even though till now the evidence is that it takes care of suicidal behavior is not very strong. So coming from the community awareness issue, I think it's important to mention that now a lot of communities do something called the QPR, which is question, persuade, and refer model, where, like for example, in organization, let's say there is an office, some people are identified who are normally working there. They are identified as people who are more kind of other-centered and more nurturing, and are ready to put some time into helping others. Then these people are given some training about how to help people who may be suicidal. So their job is to question the individual if, like, the names and contact possibilities are put up in public domain, and a person who may be thinking of suicide may approach such a person who is called a gatekeeper, and the gatekeeper then is supposed to ask the individual, assess whether the individual has a desire or intent to die. If they feel that there is such a situation, then they persuade the person to seek help and to accept help, and they refer the person to appropriate resources. So this is called QPR, and this is something which works quite well at a community level. The other important community resource is helpline numbers, and the government of India runs a helpline number called Kiran Mental Health. Similarly, Tata Institute of Social Sciences in Mumbai runs a service called iCall. These are in the government sector. There are many NGOs which also run helpline numbers. One of them is ASRA, and the others like Sumaitri, Snehi, Sanjeevani, and Fortis Stress Helpline are those which the last four are available from Delhi, while these others are available all from across the country. I think we cannot be finishing a talk on suicide without talking about COVID-19 and suicide. It's kind of known that death by suicide increases in epidemics. Like in 1918, influenza epidemic in USA, the rates of suicide went high. Similarly, it was shown that in Hong Kong, the 2003 severe acute respiratory syndrome, the rates of suicide were high in the older people. So it is expected that the rates will be high even with COVID-19. The other kind of important thing to remember is that mental health consequences are likely to outlast the pandemic. So even after the pandemic is over, we will be seeing its consequences for the next few months. And the peak of mental health problems is later than the peak of the infective situation. So when the pandemic ends, we should be ready that there will be mental health consequences which are going to continue for at least a couple of years beyond that. So this is something which has policymakers and planners have to keep in mind. Some of the reasons why people are thinking of suicide in COVID times is that there is a fear of infection, so stress levels are high. Then if a person gets an infection, there is a lot of stigma towards that person as well as the family, and that makes the stress level high. Self-isolation and physical distancing means that social support is not available, and social support is an important protection against suicide. There is reduced access to services and also fear of accessing services because of the fear that one may get COVID. So people are not coming to hospitals because of fear. And so it means that many people who have pre-existing illnesses don't get treatment. And if they have mental illnesses from before and they're not getting treatment, it's possible that the condition may deteriorate and they may think about dying. Then, as mentioned earlier, COVID has led to a lot of economic adversity at the population as well as the individual level. This definitely adds to stress. People are staying at home, so domestic violence seems to have gone up kind of many-fold, and that makes it difficult for people. And people, when they're staying home and a lot of other entertainment opportunities are not available, they are increasing alcohol and other drugs to a greater degree than earlier. So all these factors kind of add to the risk of suicide during the COVID-19 pandemic. And to manage this, there has to be certain changes, and the changes would be to have more online mental health resources available to reach people who are either not coming or cannot come to hospitals. There is also a need, equally and greater need for social action. For example, social action can be destigmatization of COVID itself, kind of making people understand that physical distancing should not become social distancing, making it possible, generating resources to make employment opportunities available, doing programs to cut down on domestic violence, doing community programs that people understand that they shouldn't be using too much of alcohol and other substances. So these are some of the response. Doesn't have to be only a mental health response, it has to be a social response also. So the take home message is at an individual level. Suppose you are faced with a person who comes to you that I may have I'm very kind of sad and I don't want to live anymore. the first thing that you have to remember is that a person who expresses suicidal thoughts may be at risk of suicide even if they have very few psychiatric symptoms. So if they say that, no, I don't have anxiety, I don't have too much of sadness, I don't have any hallucinations, I don't have delusion, the fact that they're saying that they are thinking about suicide is something that should alert you. Once this happens, it's important to develop and maintain a relationship with this person. And so you should inquire in a non-judgmental way about whether they intend to self-harm or they have been thinking about it. If they have an intent to harm themselves, try to find out how they're planning to act upon it. The other issue is that suppose the person has made an attempt or is planning something but has not made an attempt, but had made an attempt earlier, then you have to assess whether there is a risk of repetition. And this is best understood by asking them about any past suicidal behavior. If after this attempt they continue to think of suicidal ideas, then the chance of the risk of repetition goes up. If a person is very hopeless about the situation and cannot think of any other way of managing the problem, then the risk of repetition is high. So these are certain things that a person who's trying to help should be trying to assess in a person who has told them that they may be thinking about suicide. Following this, one has to identify what are the various kind of problems in their life in the psychological, social, and psychiatric domains, and try to see whether it can be handled at your level. The next thing is to ensure that there is a safe environment. So a person who has expressed suicidal ideas should not be left alone, particularly if you think that there is a risk of repetition. So you stay there with the person for, let's say, a couple of hours, and then if you are busy, you should hand that person over to someone who will stay with that person for some time. So usually a person who you feel is significantly suicidal may need other people around them for days till you are very sure that either they are not going to harm themselves, or you are kind of, if you are uncertain, then you should refer them to mental health services. So one of the important issues about ensuring safe environment is to remove means of suicide, because at the time when a person is suicidal, that is the single most important preventive strategy, that you take away all the means possible, keep them with someone so that they don't get a chance to act upon whatever they may be thinking. So staying with the person, removing means, this is the first step. And then the more kind of longer term and comprehensive treatment can continue from there. So this is what I wanted to speak to you, and the rest we can kind of take up in questions.
Thank you so much, sir.
Dr. Kaur. It has
Yes,
been really a very, very nice presentation. Galandu,
yes, sir.
देख लो क्वेश्चन कुछ है तो देख लो, और अजमेर जी आप भी देख लीजिए कुछ क्वेश्चन अगर है।
जी सर।
Yes, sir.
लेकिन
So,
एक चीज और मैं कहना चाहता हूँ कि क्वेश्चन से डॉक्टर साहब, वो बहुत अच्छी बात आपने कही जो हम लोग को नहीं मालूम था कि अगर एक बार किसी ने अटेम्प्ट किया है तो उसका खतरा हमेशा बना रहेगा। ये आपने बहुत बड़ी बात कही है कि हम लोग के ध्यान में नहीं थी, मुझे तो नहीं ध्यान था। दूसरा एक और चीज की मीन्स ऑफ सुसाइड को हटाने से सुसाइडल रेट घटा, ये भी बड़ा इम्पोर्टेंट थी। तो ठीक है, ओवर टू यू जलंधु।
हाँ जितेंद्र, जितेंद्र कैन यू हियर मी? जी सर।
sir, am I audible?
Yes. Dr. Sharma, can you hear me, sir?
Yes, I can hear you.
I
Thank
guess
you very
there's some
much, sir.
technical issues. DG sir was saying something, right?
Yeah.
I think there's some technical issue.
Okay.
Till time I sort that out, please, sir, look at the question answers. I'll sort the technical issue.
Okay. Thank you very much, sir. As you rightly pointed out that, suicide is not just a health issue, but a social issue. And it is everyone's, I will repeat, it is everyone's duty to save lives. Very somber subject we have sort of dealt with today. Now, since this is everyone's duty to save lives, I mean, I would like to ask you, sir, I mean, these days when, access to hospitals is extremely difficult and the stress levels have really gone up. And supposedly somebody, in a family, somebody with, suicidal thoughts, how do you counsel that person and while staying at home when it's difficult to reach to access hospitals? So any tips you may like to suggest that, as an individual, as a family, how can we counsel one of our family members, who may or may have suicidal thoughts?
Right. I think the first I had kind of given some hints towards this. That the first thing is to try to have a non-judgmental discussion with the person. That one doesn't say that the one shouldn't start by saying that suicide is immoral or it is illegal or it is something which is against the religion or only weak people commit suicide and you should be strong and you should. So one has to understand that this is a coping method for a person who has thought of all the other things that they could have kind of done and feel that there's no other way. So one has to listen to them as to what the problems are, why they are trying to die, and it's quite possible that uh, just listening to the person sometimes gives them a sense of relief that they have talked out, that there is something which the kind of desperation that they're feeling is something which is understandable to another person. So even just talking to them helps at times, or rather I would say not talking, it's more about active listening, like listening as a non-judgmental person is a very important thing. The other thing that one has to tell them is that you are available for them whenever there is a sense of crisis. The third issue is to kind of think the problems that have come up. One has to see whether there is a possibility of solving those problems by some other methods. And all of us know that most of the time that is true. 99.99% of the time there are other ways of solving the problem rather than by dying. So these are the usual things. Apart from that, that one thing which I wanted to emphasize is that one should not assume that every person who thinks about suicide can be handled by a community member. So one should be looking into whether the intent is high, whether the risk of repetition is high, and if one feels that there is that the condition is really problematic in the sense that they may be, let's say a person doesn't have a job, has many young children to take care of. So if you feel that it is beyond your level, you should know that one should refer the person to a person who can handle it. So on one hand, one shouldn't be too kind of, one shouldn't have a rescue fantasy that I can solve all problems. On the other hand, one shouldn't kind of feel that it cannot be handled by oneself at all, that every person who thinks of suicide has to be referred to a mental health specialist. Neither of these positions are right. The right position is to try to handle it by yourself. In case it's not doable, then be open to referring them.
Sir, in your presentation, you talked about impulsivity. So, especially in the younger lot. So, how do you handle such impulsive behaviors? I mean, what do you recommend?
Uh, look, the way of handling impulsive
I'm sure
behavior is
many parents face this problem. Handling a youngster with impulsive behavior.
there are different ways of handling it. At the level of a school, for example, there's something called life skills education. So some of the life skills education, one of the life skills education is how to make a decision. So suppose you have to teach someone how to make a decision, then we tell them that, okay, in this situation, these are the pros, these are the cons, and let's try to balance them, that which is the better way of acting. So will the impulsive way will be the better way of acting, or will a non-impulsive way be a better way of acting? And based on that kind of a decision making approach, approach, often a child or a adolescent learns that it is better to act in a more in a less impulsive way. So life skills education is something which can help them. People who are very then the other ways are like particularly with younger children. Sometimes one can kind of take care of things that if they act in ways which are not the most appropriate ones, they do not get what they want out of it. They, if they work in ways which are more appropriate, more socially kind of appropriate ways, then they are given credit for that. Uh, so that is kind of the principles of behavior therapy are there, which can be used even by parents. So sometimes it's possible to teach parents how to deal with impulsivity through something that we call parent management training. Otherwise, teachers are able to help parents. Like life skills education often is done in conjunction with the school and the parents. So parents know how to handle the thing which has been taught at school, even at home. So these are some of the ways in which it can be learned.
Yes, another question from one of the attendees. I'll just read it out. And the question is that, do you agree loss of jobs and isolation during lockdown during COVID has led to increase in suicide? And plus, all the ones at this also, that what should you do if someone tells you they're thinking about suicide? Would you like to take that, sir?
Okay, the first one, the answer is clearly yes, that social isolation as well as the loss of jobs can increase the rate of suicides. And I think in that sense, the worst is not over. We are looking, if the economy stays depressed for a longer period, then suicide rates may actually stay high for some time at least, for the next few months. About handling, like if a person talks about suicide, I think I've just answered that question a little while ago, that one talks to them non-judgmentally, one tries to understand their pain, one tries to find out their problems and try to find other ways of solving those problems. And if you feel that it's beyond what you can manage at a given time, then it's important that you refer to a person who can handle it, which is a specialist usually.
We have a couple of other questions, sir, and it's a very, as you said, very somber subject we're dealing with now. Question is about exams. How do you handle family pressure while preparing for civil services exams? And at times it becomes unbearable. So,
The issue is not only about civil services exams. There are certain exams which are kind of considered to be high stakes exams. So in fact, the younger people who get into high stakes exams, there, let's say I'll give you an example of people who go to quota for doing cracking. The word
that's
is
right.
cracking medicine. So they go sometimes in the ninth class when they're 13 years old. From ninth to 12th, 4 years, they are staying in a fairly isolated thing where there are a few peers who are the only social support that they have. And from the morning to the night, they are working on trying to study or dealing with like suppose other people are doing better than them and they are not doing well enough. They are under tremendous stress as to how they will compete with people, how will they live up to the expectation of parents who may have given large sums of money to put them into this situation. Something, so a person who's 13 years old and is put under this kind of pressure, it's difficult to handle. And the same thing would be true even for civil services aspirants. They're slightly older, so maybe they're actually a little bit better equipped to handle stress in certain ways. The the answer to this is largely societal, in the sense that we have to have multiple ways of in which people can find social acceptance in terms of what kind of jobs that they're doing. Like if only medicine and only IAS are the ways in which people can gain prestige, then this problem will continue. So the way the country is dealing with its uh, prestige related to jobs will need to change for that. Otherwise, At an individual level, of course, one can talk to the person, one can talk to the families, one uh, helps them see this part of it, that life is not only about one thing. One doesn't have to be very perfectionistic or very inflexible about what one wants to do in life. So this works for the individual concerned, and also sometimes one needs to intervene with the family. So sometimes sense needs to be noted.
No, no, well said, sir. And Jalendu, DG sir had a question. If you could please check with them.
Yes, sir. Yes, sir. His net is working fine. It was from my end. So, DG sir, over to you. Sir, your voice is not audible. Sir, it's still not audible. Maybe some technical issue.
Just bear with us for a second. There's a bit of technical glitch, sir.
Sure.
I guess there's some technical issue, sir. Anyways, Ajmer, sir, please continue with the other questions. I feel there are many more important questions in the chat box as well as the Q&A.
Okay. Sir, one of the question is that how do you recognize the potential victims and how do you stop them, sir?
Okay. There are multiple layers of interventions. Like at uh, the first level is called the level of the self, where sometimes we can have, like particularly through the internet, one can put out questionnaires which pick up depression, and the most depression questionnaires also have one small item on suicide per se. So some people can fill up the questionnaires themselves if they feel that they have some amount of suicidality. Now there is possibility of treatments which can be activated by the self. Like there are chatbots. Chatbots are they have kind of a question answer schemes where the person says, okay, I have this problem, and the chatbot then asks, what is why do you think you have a problem? The person gives a particular answer. So they have these trees which are available. So sometimes individuals can fill up a questionnaire by themselves by going to a particular site, and then the site has ways of answering it without anyone being involved at all, uh, till a certain level. And if the problem is kind of uh, the chatbot feels at some point of time, like the artificial intelligence logic tells it that the thing is more severe, then a person is alerted that, okay, you should now talk to this particular individual. So that is the self-help level. Then the second level is the community level, where we talked about people who are called gatekeepers, where they are well-meaning people available in the offices or schools or colleges and other places. And these people can are usually more approachable because the person knows that this person is in the community and not is not stigmatized as a mental health professional kind of a thing. So that is the second level, which is available in the community. The third level is professionals like the helpline, which are anonymous, but people may reach out to them, or they may be counselors in schools or in colleges, sometimes even in offices. So that is the third level, and then if things cannot be handled here, then comes the more kind of professional groups, which are psychiatrists and clinical psychologists, for example. So there are multiple levels, and people can be picked up by themselves, they can be picked up by the families, they can be picked up by other community volunteers, and so on.
Another question, sir, it's about teens. teens these days are under tremendous stress, and the problem is they don't really open up to the adults, to the parents or the family members. So the question is that how do you what is the best approach to keep them motivated?
Uh, okay. With teens, that question actually has two parts. I think one is how to kind of take care of the teens, and the other is how to manage the substance use issues. About the teens, I think it's important that the community aspect of it works the best with them. So, let's say if there are schools which are available, then teens will tend to get involved in positive mental health activities. Like suppose there are clubs which are related to hobbies. For example, if there is a club on writing, there is a club on discussing some important topics, painting, dancing, other kind of things. So people who may have suicidal thoughts, if they are part of clubs, they will open up to someone or the other because they feel close to them. So having more of these kind of positively oriented things, not about that if you have suicidality, you go to a particular person. It's more about they tend to become engaged with these kind of clubs, and if these are available, then they also tend not to do some of the negative things that are there. So trying to get more people involved in groups and is one kind of a useful way of handling teens. In terms of substances, it's important that institutions should have clear-cut guidelines about how they will handle substances. So students should know, and teens should know that the substance use is not legally permissible. For example, for teens, like in Delhi, for example, the drinking age is 25 years. Many of the substances that people use are illegal. So these are things which people should know, and what are the possible kind of consequences. And also, more importantly, they should know that there are many other teens who now, there is also a big movement amongst teens themselves who feel that substances are not the best thing. There was a time when they used to be considered cool. Now the coolness coefficient is coming down a bit. Like smoking is not considered cool anymore. Alcohol is kind of getting into a situation where people realize that it is not all that. There is a group of students who are now beginning to move against the concept that substance use is a kind of panacea, or this is something very great, and probably they can be helped to reach out to other people who are using it without stigmatizing them, but trying to build a dialogue around it. So my answer would be twofold. One is positive mental health, things like club or community activities, and the other is engaging teens themselves to work as peers who take care of the problems.
Jalendra, is the technical thing sorted out? DG sir had a question. Could you please check with them? Can you hear me, Jalendra?
Sir, DG sir is not connected with us. I think there is a technical issue with his computer only. So
Okay.
I think she should continue with the questions.
So DG sir has joined. Yes, he has joined.
Sir, but he is not able to not audible. Yeah, he will not be able to speak. He's mute.
Okay. So with your permission, can we take one or two more questions?
Yes, sir. Please take questions.
Dr. Sharon, with your permission, sir?
Yes, sir. Sure, please go ahead.
Okay. No, sir, another question is that though you've answered most of the question, but still, that people have died by suicide on account of mental health issues and due to depression, stress. So what do you suggest that, how should people cope with depression and stress?
Okay. Again, as I mentioned, that some uh, methods are available where a person can self-treat themselves in the sense that, as I said, there are certain sites, there are these chatbots which take care of depression. So there are some chatbots which run on Apple computers, there are on Apple phones, there are other chatbots which run on Google phones, and so on. And there are certain NGOs which are running these kind of activities. So it's possible for people to assess themselves and to treat themselves without involving anyone else. That's the level one kind of a thing. Uh, Beyond that, depression can be handled through what we called uh, positive mental health activities. Like meditation is one set of activities which can take care of depression. Uh, Physical exercise, if it is done on a regular basis, if people do about 40 minutes of aerobics about 4 times a week, it decreases depression in about 60% of people. Meditation also and yoga, for example, if they're done regularly 4 times a week, approximately about 40 minutes a day, uh, if people do it in a trained manner, these can lead to decrease in depression and anxiety. So these are positive mental health interventions: meditation, yoga, exercise. Apart from that, there are now kind of there's something called bibliotherapy available, where there are books which teach people how to do CBT for themselves. So these are the things which can be done at a personal level. Beyond that, one can obviously go to counselors or to mental health specialists. So uh, some of the more kind of severe or things which do not settle down by themselves, they can be taken up by the more professional groups.
So another important question we have from this lady, she's been working with teenagers, especially living in hostels. What she's saying that many of them, especially from rich families, and she's also indicated apparently from broken families in hostels, they have a lot of freedom. They have experimented with drugs, consensual sex, and have a tendency to harm themselves. So she is worried that, can this, this lead to sort of suicide? And what do you advise her? What is the best way to sort of handle this, sir?
Okay. The way to handle issues like basically we are talking about broken homes. Being from a rich family per se may not be a disadvantage, but being from a broken home will be an issue. And uh, similarly, cutting behaviors would be an issue. Consensual sex will be a problem, particularly if it is done in a way which is not stable at all, in the sense that a person relates to one person, then a person to a second person. And so if there is a lot of promiscuity, the problem is not necessarily the sexual part of it. The problem is the lack of a stable relationship part of it. So if a person is trying to get affection which is missing from a broken home by getting into multiple relationships, that is the problematic situation. And what we need to do is to be able to provide such a person with a stable human relationship where they can come and discuss their kind of joys and pain and sorrows and other things, so that they stop depending on random people for the support that they are seeking. Uh, so usually a psychotherapeutic relationship works pretty well for individuals of this kind. And when she mentions that some people do self-cutting behavior as a way of handling pain, again, these individuals have to be taught to handle their problems in ways other to learn other coping methods, which may be through uh, techniques like I mentioned earlier, the cognitive behavior techniques, or uh, the a CBT which involves meditation or dialectical behavior therapy kind of techniques. So there are techniques which can be taught to them, which may help them to deal with their pain in a more a kind of more functional ways. Cutting behavior definitely is a dangerous behavior, and it's something which should be seen as possibly pro-suicidal. One should not take it very lightly. If a person does cutting on a regular basis, they should definitely be taken up for treatment.
Oh, thank you very much, sir. And I think we're done with Jilendu. If there are no more questions, hello,
Yes, sir.
Jilendu. Yeah.
Sir, DG sir is again his audio is not getting connected. Anyways, so I don't think there are any more questions yet. I would really like to thank Pratap sir. DG sir is still there, present with us. So on behalf of him today, I would like to close the session by saying thank you all the attendees who were present here. We highly appreciate. We have another very important webinar coming up tomorrow, which is on when to see your cardiologist. It is a very crucial thing as the one which was today. I would really like to thank Pratap sir, Ajmer sir, and DG sir that this initiative has been taken and this awareness has been spread among the public. So everybody who joined us, please share it around with more and more people because through these initiatives, even if we have been able to help and we will be helping more and more people, that's the aim which our DG sir has visioned. So thank you everyone. With that, I would like to close the session. Thank you, sir.
Thank you.